Krishni, we're now live streaming.
Thank you very much, Tom. Good morning, everybody, and welcome to our Integrated Care Board meeting in public. It's the first one of the new financial year, so welcome to everybody. I think we have all our colleagues here. Matthew Hopkins is going to be a little bit late, but will be with us. So we've got no other apologies. Before we start the formal items on the agenda, I'd just like to say thank you to colleagues across the system who've worked over various holidays since we last met. So I just wanted to express that thanks. Have we got any declarations of interest for items on the agenda, please? I'll ask you to raise your hands in the usual way if you have. Okay, I don't see any, so thank you. We'll note that none were declared. If anything does arise during the meeting, please take the opportunity to note a conflict of interest. We have our governance log on the agenda as usual. There are two actions open, but both of those are not due until we're going to have them on our July meeting, so nothing outstanding. One of the things that I've discussed with Hannah is that we noted that our decision log has started again as sort of fresh for the new year, for the new financial year, but it might be helpful to have a sort of rolling log that means that any decisions made in the last few meetings are still visible. So we'll organise that for the next meeting in July. The minutes of the previous meeting held on the 15th of March. Thank you to Sarah Raystrick, who chaired for me and did a great job, and excellent minutes. Thank you. Are there any points of accuracy that anyone would like to highlight? Otherwise, we will approve those minutes. Any points of accuracy? No, thank you very much. I'll take those as approved. I think the only matter arising that I didn't pick up on an action log, and I wondered if Hannah could comment on it, that there is a reference on page 9 of the minutes about risks oversight group in place to oversee the transfer of pod services. There has been no information forthcoming with regard to a legacy risk register, but the ICB is producing one and that will be presented to QRD. So Hannah, I just wondered when that might happen.
Yes, thank you, Krishni. So the pod services, just similar to primary care, will be part of our delivery and oversight and will be subject to QDOS. We are currently in the process of setting up 2 programme boards, one for primary care and one for pod services, and they will then be subject to the same reporting and risk reporting through our quality delivery and oversight subcommittee up to QRD. So that's not happened yet, but it's in the process of being arranged, and we should see reporting to QRD in July.
Brilliant, thank you, Hannah. So we will move on then to our patient and public voice section. We do have a question from a member of the public, and I'll just read that out. When will the removal of additional barriers to IVF for female same-sex couples announced in the first Women's Health Strategy on the 20th of July take effect in our system? The strategy states that there will no longer be a requirement for same-sex female couples to pay for artificial insemination to prove their fertility status, and NHS treatment for female same-sex couples will start with 6 cycles of artificial insemination prior to accessing IVF services if necessary. So I think Will Taylor, who's our medical director, will be responding to this question. Will?
Yeah, thanks, Krishni. I hope everyone can hear me. I've been having trouble getting my microphone to work, but yeah, no, it's a really important point. And as an ICB, we do seek to avoid any discrimination of any kind in all our clinical policies. And I'm really glad this has been raised. The Women's Health Strategy for England is a 10-year strategy which sets out actions aimed at the government alongside other relevant organisations, including NHS England and the National Institute for Health and Clinical Excellence, NICE. our ICB commissioning arrangements for fertility services, including the requirement for demonstrating infertility for both heterosexual and same-sex couples, are based on that issued by NICE. These NICE guidelines are currently being reviewed, however, following the publication of that Women's Health Strategy, and the updated national guidance are expected in 2024, so not too far away. We've reviewed the existing commissioning arrangements for assisted contraception services following the publications of the Women's Health Strategy for England, and will review our local arrangements following any updated NICE guidance coming out.
Thank you very much, Will. Really helpful to hear that response, and thank you to the member of the public who raised that question. Okay, unusually today we have a people story. We've got a bit of a people theme running through our agenda today, and therefore we will be hearing a lot from Katie Hartwright, our Chief People Officer. So it's over to you, Katie, for the people story.
Thank you, Chair. Hello, everybody. Nice to see you all. So today I'm going to be telling you the story of Kevin, who is an international nurse recruited into Wye Valley. The reason we picked particularly an international nurse is that last week it was International Nurse, it was Nursing Week, and international nurses is one of the strategies we have to manage some of the vacancies that we have across our system. So understanding the experience of our international nurses is a really good thing to do. So Kevin joined us. He was born in the Philippines, and he was brought up there, trained and practiced for 10 years as a nurse in the Philippines. And he was recruited via an agency to work at Wye Valley in 2019. When you come across as an international nurse, you need to do what we call OSCE training, which is to allow you to practice in the UK. So while he was going through that training, he initially worked as a healthcare assistant, and then became a OSCE qualified nurse here. And then he worked on a respiratory ward throughout the COVID pandemic. Kevin had never left the Philippines until he first came here. This was the first time he'd left his own country and come across here. And some of the things that he said about what was so good about the process was that his feedback was really fast when he went through the recruitment process. He got a job offer very quickly from Wye Valley, and that sealed the deal for him because he felt really valued and he felt like he would be able to make a difference here. He really loved the personal touch, and this comes out a lot from our international nurses. The personal touch from the pastoral teams is really important. And he gave a particular shout out actually to Karen and Charlene in the team in Wye Valley, who made him feel more like a family than an employer. And the thing that he particularly mentioned is that he was on a 24-hour flight to Heathrow and then into Hereford on a coach. He was shattered by the time he arrived. He was met at the station, he was taken to his accommodation, and he was provided with a welcome grocery pack, which got him going for the first few days. And he said that was so important to feel valued and welcome. The thing that's really great for Kevin is that he's been encouraged to fulfill his career potential and develop. So he's not only been working as a nurse, he's also had a secondment role as a practice facilitator. So he's supporting other internationally recruited nurses through their OSCE training now. And he's moved across actually to the University of Worcester, which is a great recognition, I think, of us working together as a system, because he's now supporting other international recruited nurses as they go through training. And he's working with another partner in our system. He's received an award from the RCN for making a difference. He's a professional nurse advocate. He's a member of our Black, Asian and Minority Ethnic Network, and he sits as the chair on the National Community of Practice for Professional Nurse Advocates. So he's done a huge amount since he's joined. He's a big advocate for our system, and he's really enjoying the career experience that he's having here. He talked about what's really important, some of the positives that he thinks are important when we do recruit international nurses. So that feeling of feeling valued and welcome comes out hugely in what he says to us, but also being able to develop. He said not all international recruited staff have the support they need to reach their potential, and that's something we could look at. And it's important to see international recruits in terms of what they bring rather than what they lack. He has had the odd comment from time to time about his accent and his use of language. So he's been talking to teams about what we can do there to make sure that doesn't happen. And he wants to make sure that everybody's got access to the mental health and support that they need. He found COVID, as many people did, a very difficult time. So he's given us quite a few things that we could think about and work on. And I know that the pastoral teams across the system are working hard to make sure that everybody has an experience like Kevin's received, and that we can then enable the career development of those people throughout our system. If you want to hear more about Kevin's story, we've actually had a video made of him being interviewed by our EDI lead, Dave Morgan, and that's going to be on our website by the end of the week. So you can hear Kevin's story in his own voice later on this week, but that's Kevin for you. Thanks, Chair.
Thank you very much, Katie. I think that's a really powerful story about the importance of the support we provide for people who, you know, recognising the significance of the change that people go through when they're coming in to work with us and support us, having come from a different country. So that whole pastoral support and the quality of the experience, it sounds like that was really well handled by Y Valley, and I think that sort of sense of cultural sensitivity that we need to have for people who come from different cultures and bring that richness to us. Any questions or comments from other colleagues? Ammon?
Yeah, Katie, I was just going to ask, it sounds like Kevin's had a really amazing experience at Y Valley. How are we taking the learning from that and applying that across the system?
Thank you. We're doing that through our EDI work. We've got an element of, we're speaking to all of the trusts and all of the organisations in our system that do employ international recruits, and learning from them about how we can support their efforts. There's quite a lot of conversation about pastoral care and how we can create communities of practice amongst us all so that we can share that learning. So there's quite a bit of work going on with that at the moment.
Thanks, Katie.
Great, thank you. Graham?
In fact, great question, and Anne, I was going to ask very much the same, but with a slightly different twist on it. Is simply to say, sharing best practice is great. Have we got any assurance that that is actually Kevin's experience is actually being experienced by international recruits at the moment?
There are various surveys taking place actually where we're polling how people are finding the experience, and the region's going through a polling process right now, and we're encouraging all our international recruits to respond to that. So we won't only have their responses for our own system, but we'll have the benchmarking across the region.
Thank you, Graham. It's certainly an experience we would want to repeat, and that's the key point, isn't it? Jane?
I guess just a final point, because you're right. One good experience doesn't mean everyone's had a great experience, but I mean, it is an area we're extremely proud of, actually. But we've got a brilliant team, and great to have a shout out for Karen and Charlene, because they absolutely lead it. And it's a really human approach. You know, it's about treating individuals as individuals, and you know, in the departments and wards that they're working in, and you know, as part of our culture, there's very much a family feel. But the proof of the pudding really is in our retention rate, and we've retained over 90% of our international nurses who we recruited over the last 3 or 4 years. So I think that's really the proof of the pudding for us, is that the vast majority are staying with us.
Great, thank you very much. Thanks for the story, and thank you, Jane, for that comment as well. So we'll give Katie a bit of a rest before we bring her in again for a big chunk of our agenda today. But it's now over to our strategic updates, and for this meeting we've got quite a very comprehensive report from Simon, our Chief Executive, and so I'll hand over to you, Simon.
Thanks, Christine. And I'll start by saying thank you to colleagues and Hannah in particular who've helped me pull the report together and make it as comprehensive as it is. This is designed to set the scene for some of the other discussions we'll have later, really, and just provide the range of information about the enormous work agenda covering a whole range of issues right across the health and care system. So that's what it's intended to do. We're going to keep working on refining the report, but it is comprehensive and detailed, and we make no apologies for that, really. Just, Christy, to pick out some highlights if I can. I mean, the first part of the report covers the operational context. Challenging, remains challenging. We had some improvements, I think, in February for probably one of our biggest operational issues, which is ambulance handover delays. More concern emerging over the last month or so that we haven't quite got that right yet. And the issue in particular is we're still having higher levels of ambulance handover delays in Worcestershire, particularly relative to other systems. Other systems seem to have really made some sustainable improvements, and we've still got a problem. Certainly on some weeks it's particularly bad. So the main focus of the work over the last couple of months have been twofold, really. We've done some work around the whole discharge and community services operating model, the onward care team that Lisa Levy has led for us. And we've had, as the report mentions, a chap called Dr. Ian Sturgis, who used to be involved in the emergency care intensive support team nationally, but is now working on a freelance basis. Ian's worked with us before, and we asked him to come in and look at particularly why we've seen some length of stay increases in Worcestershire, and Ian's come up with a really good focused report. And obviously we need to really now focus in on the actions that he identifies, which are largely about the way the hospital works, the flow within the hospital, not really identifying huge issues with the front door demand management, or even actually with the discharge processes when a patient is going on to have further care needs. It's what's happening within the hospital and how the A&E department and the medicine division and the specialty medicine division and all the other parts of the hospital, how they are supporting that process. So that's going to be our focus over the coming weeks. And of course, attention is turning to, we will hopefully later this year in the autumn, the new emergency department at Worcester will open. So just making sure over these summer months that the operating model is right and will work and will give us the benefits that we're hoping for when that new building opens. Lots of strategic work that the report covers. David has done a lot of work with partners on the joint forward plan, and Emily Godfrey has led an exhaustive process to get us an agreed operational plan for this financial year. Mark will touch on some of that in the finance report, but I really wouldn't underplay the effort that went into getting that plan to a level where it's considered acceptable from right across organisations, really, not just from the ICB, from all the partner organisations as well. I can turn to page 7. So a big part of our work is we're trying, aren't we, to get more place-based ownership of some issues. One of the things that the place structures are working on is the integrated urgent care model and the GP out of hours service. So we have GP out of hours contracts that at the moment run out in July 2024. So we need to get to a place really by this July or soon afterwards where we have a clear idea on the model that we'd like to organise moving forward. We all agree there are real opportunities because there's a lot of duplication with when the GP practice officially closes, which is kind of 6 o'clock at night, 8 AM till 6 PM. There's a number of additional services that come into effect. One is the traditional GP out of hours contract, which is for patients that need GP services that it's an urgent need and they can't wait till the morning. But we also have so many bits of extended GP access which bob around all over the place, and the idea with this integrated model is to try and find a way of integrating that offer, joining it up, removing duplication and making it a bit easier for patients. The models that are being developed are very much place owned, so a model in Herefordshire and a model in Worcestershire, and we'd like to be in a position to bring some ideas and proposals and a recommendation to the July board, which will come around quite quickly. I'd also like to point out on page 7, Christian, if I can, a CQC report at Worcestershire Acute Trust. So despite some of the performance issues around urgent care, actually the CQC rating has improved for urgent and emergency care services from inadequate to requires improvement. So congratulations to Matthew and to Anita and the team. So there's a lot of work to do, but that does give me some encouragement that we are heading in the right direction. And the CQC play a big role in determining the level of scrutiny in particular that we get. And I'll just finish on the final page. So I know most people are aware, but congratulations to Matthew Hopkins, who has been appointed to a new role in Mid and South Essex NHS Foundation Trust. Matthew will leave in a couple of months or so. Just to flag, I know board members are aware, there's a series of conversations that are happening led by Worcestershire Acute Trust Board, but involving us and lots of other partners around the right answer for that succession plan for Matthew. And we'd hope to be in a position in the coming weeks to confirm that and to move that forward. So very happy, Krishni, to take questions on those issues or anything else in the report.
Thank you very much, Simon. Any questions or comments from relating to Simon's update? David Whiteman.
Yes, thanks, Chair. Simon, thanks for the report, very comprehensive as always and really, really informative. On the Sturgis report, there are still 14 recommendations, and I think 14 is a lot to focus on. So can you point us towards the kind of 2 or 3 recommendations which will make the greatest impact? And I would like to see us focusing on the ones that will give us the greatest impact, so we make sure those really do land.
Yes, David, I would agree entirely. I mean, 14 is the headline number. A number of the 14 are covered already in existing action plans, so they are less of a concern. I think what Ian Sturgis has highlighted to us is the absolutely essential need to develop some of those pathways within the hospital. So the most important bits are how medicine and specialty medicine supports A&E, how patients who could go directly to an assessment unit in the hospital, and there are a number of assessment units or a same day emergency care unit, how they are able to access that unit without having to go through A&E first. So that's the second one. And then the third one is really, when patients are discharged from hospital, we've got to make it earlier in the day. So far too many are being discharged later in the afternoon, the evening, or even at night. And obviously what happens is if you discharge 30 people a day and you admit 30 people, you have to get the timing right. And if you aren't discharging people till later in the day, what actually you're getting is a queue of people outside waiting for space to become available. So those are the 3 most important elements of that Ian has highlighted to us. That I don't think any of them are a massive surprise, but that Ian has given us some useful indicators of things we could do to move those forward. So certainly those 3 areas are where my focus, and I know Anita and the Acute Trust Board will also be focused on over the summer months.
Thanks, Simon.
Thanks, Simon. Just a point of clarification, Simon, if I may. I'll use Chair's prerogative to quickly clarify something before anyone else comes in. On the same point regarding the action plan, one of the items you reported on was the quarterly system review meeting, where we were asked to finalise our action plan and share it with regional colleagues. I think we're due to do that. So has that happened, or is that about to happen through the course of this month to report back to region?
Yeah, I mean, that's the deadline. We got to the end of this month. There's another couple of weeks to finalise the detail, but work is ongoing to be crystal clear on the actions that we intend to make, the changes that we intend to make to some of the operating models. So you're right, Chrissy, to point that out. That is one of the asks of us by NHS England.
Thank you. Right, let's bring other colleagues in. Graham first.
Yep, thank you, Krishni, and Simon, as David said, fabulous report, really informative, so thank you for that. And Simon, if you wouldn't mind, I wonder if I could ask a broader system question relating to children's services. Could you just give some assurance that we are giving all the NHS part is giving all support that it can to the local authority? And do you have any update on where the plans and the recovery is on children's services?
Yeah, Really insightful question, Graham, and that's not actually covered in the report this time, is it? I mean, Paul may want to come in as well at some point, but we've got in children's services improvement journeys in both of our counties, and they are at different stages. I do think Worcestershire actually are on the brink of getting recognised really with some of their progress. There's a range of inspection activity that's taking place, and I think there's a lot of optimism around recognising that. My only caution would be, and it applies in both of our counties, what we're seeing right across children's services in the health and care sector is a huge uptick in demand. So that the pandemic, both the backlog of need that was built up through the pandemic when services didn't run as we would have wanted them to, but also additional need that has been caused by the pandemic, that they are creating a pressure. So a big part of our issue, and particularly for Jane and Sarah in organising some of the services, is making sure we're trying to get the right level of capacity that matches that need. And Herefordshire is a good example. So over the last few months, I know we've invested specifically in some children's paediatric additional capacity that Jane is running, but also some additional autism diagnosis capacity for under 10s, because that's where the big problems are building up. I mean, I hope the NHS continues to play a full part in supporting both local authority partners in that improvement journey. It's certainly, and I would reflect back, you know, if you wind back 5 years, children's services features very prominently in comparison on our agenda and in our diaries as it would have done 5 years ago. And I think that's a really good sign because it shows our level of engagement. Paul, your hand's up as well, but did you want to add anything from a local authority perspective?
Yeah, I'm happy to. Thank you, Graham. And I think Simon's right. We've got an ongoing series of inspections and visits. In Herefordshire, we've just come through our first Ofsted Focus visit. The report from that will be published in mid-June. But, you know, that focused on two areas. One was the MASH, and secondly, in terms of quality of assessment. And I think, you know, pleased to be able to say that the work and progress we've made over the last few months in the MASH, and that's all of us together in working on that, the multi-agency partnership, our front door, and the progress that have been made regarding the investment in resources, the investment in leadership and management, and the responsiveness of the service were all recognised, and that will come through in the formal report, and that's good and positive. Over the next 2 months, we will have the Commissioner's 3-month review. We will have a second visit by Ofsted, and sometime before September, excuse me, we expect to have a full SEND inspection under the new regime, which is particularly challenging given the experience from others who've been through that. And that really is a partnership system-led inspection around our SEND service. So that will be challenging for us. But to be fair, I think as partners, we've picked up the mantle. There's been some good coming together and focus on capacity and capability, and investment made where investment hasn't been, where we've been lacking in previous years, if we're being fair. We start from a very low base, and you know, my mantra around long-standing and deep-rooted issues within the service, particularly around quality of practice, you know, we've got some progress to be made, but we've seen some early signs of improvement, and that's good and positive, Graham.
Great, thank you very much, Paul. Is that the point you wanted to cover anyway?
No, I had no, I couldn't. I was many things, but couldn't read Graham's mind there. I had three things for Simon.
By all means, you have the floor, Paul. So do.
All right, thank you. Just on a few things, Simon, if I may. Really pleased to see the health and wellbeing strategies get a mention from both Herefordshire and Worcester. I think that's good and positive, and I think for me, in terms of the Health and Wellbeing Board, where, you know, we'll have the oversight of those strategies, an opportunity post-elections within Herefordshire to kind of reset the tone with the Health and Wellbeing Board. But it was just a little bit of, and maybe it's a terminology for me. You guys are all used to it. Well, can we find a more user-friendly word than left shift, please? Is that possible? And we will play our part in trying to find something which is meaningful for all of us, and the residents that we serve. But on health inequalities and prevention, I know there's some good work started there, and in terms of the outreach service, and that will develop and grow from a very low base in terms of where we are now. I think we're in a stronger place now, Simon, in terms of making more of a contribution to that work. So I thought through Matt, keen to, through use of our public health grant, I think there's some work we can do to add there. So happy to talk about that separately and offline. But I wondered if in future we can understand a little bit more about the statutory duty we have as an ICB to reduce health inequalities and what that looks like. And then thirdly, from me, around primary care access recovery plan. And it'd be good to better understand what the recent announcements around pharmacy access and pharmacy services means and whether that makes a contribution. And perhaps a plea for a future item coming back around the community paradigm work that that you and I are both involved in, may well be potentially a subject of a future workshop item, as we understand what community paradigm means and how we can collectively get behind community paradigm and agree those local priorities, sharing of resources and handing over some of our power to deliver some of those things in the longer term. So that was the three from me, Simon. Thank you.
Three really good and relevant points. I mean, I'll start with the latter. So for those of you that aren't aware, the community paradigm is some work that Paul and Healthwatch Herefordshire actually are leading on, all designed to kind of build community capacity, to do a little bit more, build resilience in the community, to be more self-sufficient, but with support from the statutory services in the background, but with communities very much owning that, which is really interesting, I think, and we're really invested in that, aren't we, and trying to support that. So I think that would be something useful for us to consider. I mean, it relates a bit to the health inequalities work, which remains really important to us. It's easy to lose sight, isn't it, of our 4 statutory duties, and that's one of them. We get caught up in a lot of operational issues. We've been caught up over the last couple of months in some very tricky and sensitive planning and financial issues. We mustn't lose sight of our statutory duties, and I know Krishni won't allow that to happen. So there's a lot of good work going on around health inequalities. I mean, for instance, we had a really good session yesterday in the executive team about dentistry access, because I do think that's another real health inequality around dentistry access, in that the people mostly in this area who are accessing dentistry are doing so because they're paying privately, and it becomes something that drives the inequality. So I think there's lots we can do around that. Krishni will have a think about how we play that in, I suspect, to the work programme, but it would be a good idea. Just like today we're trying to deep dive people, I think we could easily do a health inequality session, couldn't we, over the next couple of meetings. And Paul, that's good to hear about the Herefordshire contribution to the outreach work. So we've struggled a little bit. We have this, we've talked, I think, at board before about this bus that we're entered into an arrangement to have use of, and the idea being the bus will go outreach to communities and offer a range of access to services, screening, testing, advice and support. Be great if we could just make that a comprehensive offer in Herefordshire as well. So we will pursue that with Matt. And just to finish on the primary care access, so it's been quite strange the way this has been announced. So first of all, leaks out over the bank holiday weekend to the press, and we've had dribs and drabs of information to follow, but there's still quite a bit more. I think the pharmacy thing is really interesting, but it has yet to be followed with any of the detail around, well, and this is the funding that will be available to pharmacy, community pharmacies to offer these additional services. These are some of the workforce solutions that will increase capacity in community pharmacies, because of course, you know, we have constraints around capacity in pharmacies, just like we do in GP practices, in hospitals and most other services. So there are some important bits of that jigsaw which I think are still to be revealed, but we're watching with interest, aren't we? I think, as we've touched on before, our GP access, relatively speaking, is really good in these 2 counties. And actually, when I look at the announcements as part of the national plan, the big one, for instance, was about digital cloud-based telephony. All 79 practices in our GP practices in our area already have digital cloud-based telephony because we've invested in it in the last 3 or 4 years. Yeah, that might bring opportunities. We need to look at the funding streams, but actually, I do think for us, a lot of this plan is people levelling up to the standards that we've set locally within our general practice. But we need to understand the detail, and we'll be looking to make the most of every bit of new resource that's available. Christian, is that okay?
Thank you.
Yeah, thank you very much, and thanks for that contribution, Paul, as well, and the response from Simon. We absolutely want to get health inequalities on our agenda. I think Hannah and I have talked about having that certainly in the coming months, because we felt it was important, exactly as Paul and Simon have said, not to lose sight of that key expectation of the ICS and the ICB. So that's definitely something we can address. And David Mahaffey, I think, has suggested that one definition for left shift is shifting towards more prevention, because really that's really what we're talking about, moving things upstream, aren't we? And I'm sure that we can work on that, and others will have commented on that as well. So I think that's a really good point about making our language accessible. And just whilst we're talking about the health and wellbeing strategies, etc., we did have a very positive integrated care partnership assembly recently, and where we sort of rubber stamped our final integrated care strategy and effectively sort of launched it. So it was a really comprehensive discussion where we talked about how important the various ambitions we had within that were. So I will move on now to, let's see who's next. Nigel, please.
Thank you, Krishni. So mine's a question about the NHS oversight framework, which has been mentioned in the Simon's paper, and really a question about whether that process needs a review, really, because we know we're moving to a system where there is going to be CQC inspection as a system. We're having considerable transformation amongst providers. We've got primary care operating at scale, and I wonder whether that should be included in that sort of process, because it just seems to be very trust focused.
It's a really good question, Nigel. I mean, you allude to the answer to the question in your question, in that the inspection regime for systems is still evolving. I think we'd all have preferred it to have evolved a bit quicker, so we were clearer. This is trust focused. It is a very NHS England centric process. I mean, I hesitate to say this, but I'm not sure colleagues pay an enormous amount of attention to it. It kind of happens in the background, and we get on with doing the best that we can. I would really hope in a year or two that the system-wide assessment covers exactly the type of things that you mentioned. So all of those blurring of the boundaries we're trying to do, that's really important, that we reflect that, because we don't want organisations to work in silos or on their own. We want organisations to be helping and supporting each other, and I would really hope the oversight framework that emerges absolutely reflects that. It should be an incentive for providers to do more and more of that. You could argue that the current oversight framework actually encourages providers to kind of manage their own business and not worry too much around what's happening around them. That doesn't happen here, and it will be great. It will be great when the inspection regime catches up with that, I think.
Yeah, thank you, Simon. I do think, you know, there will be obviously more and more system focus, and that's been clear from actually everything NHS England is doing, but also CQC, I think. I think providers do probably care about it, because ultimately it dictates a level of autonomy you have, and I think that is something we should strive for. We want to be as strong as possible as organisations, so that we are in control of our own destiny. So to some extent, you know, even as a system, we will be rated, and we are rated. Actually, the higher we are up on that scale, the more we're in control of our, you know, we're more empowered, I think. And certainly, having worked in a provider setting, that's certainly my experience. It is but it is something, I think, Nigel, that is developing and is recognised as needing to develop to take account of the system focus that we've obviously got now. So thank you for the question. Finally, we have Jane first and then Sarah Raystrick. So Jane, please.
Thanks. Really a comment that from the One Herefordshire perspective, there's real excitement around integrated urgent care and the out of hours procurement. We've spent a year working on a integrated urgent care blueprint, which has now been agreed across partners. Now there's a number of phases to that and lots of things that we can already get on and do, which we're doing. So we've co-located our community integrated response hub with the GPHRH service as a, sort of a real coming together and really integrating that. But it is about, as other people have said, it's about blurring the boundaries, it's about improving access to care. But the out of hours procurement is a big piece of that jigsaw, and a real opportunity for us to do, as Simon was saying, reduce the duplication and therefore reduce the cost of delivering better urgent care. So we're really excited about this, and we've been working on it for quite a long time. So so pleased it's going to be coming back to our board in July.
Great, thank you, Jane. Anything you want to add to that, Simon?
Yeah, I mean, the only point I would want to stress is, so this is one of those things as well where we need the national policy and the legislation to keep up with the progress we're making. So as things stand today, the procurement laws that we have to work within are the same as those that CCG's had. So obviously the new Health and Social Care Act that created ICBs also promised changes to procurement legislation that would make it easier for locally based integrated service proposals to be selected through, I think they called it a provider selection regime, didn't they, which gave us much more discretion. One of the issues we're dealing with is the law hasn't yet changed, so we still have to make sure we're operating within the frameworks that we previously would have done. So that's part of the debate we'll be having in July. It's the risk of this has to be procured on a very open, fair and transparent basis. Yes, we know we've got some local service models that have developed that look really attractive. We just have got to have a level of confidence before entering into that procurement process that those local models will be the ones that emerge. Because if we're not careful, this could have a further fragmentating effect, couldn't it? Because it could make services less joined up. So that's part of the work that's happening, is the practicalities of working within the current procurement law, which doesn't give us yet the flexibilities that we would want ideally.
Nigel, did you want to come in on this specific point, or was it a separate point?
I just wanted to just log a conflict because I'm the chair of an organisation which is the current provider of the out of hours contract, so I think it just should be flagged just for transparency.
Yeah, great, thank you, Nigel, thank you. Okay, Sarah Raystrick. Sarah,
thanks for the report, Simon, and the depth that it goes into. My point for comment really is raised on the quarterly system review meeting, and there's a table there with key actions from the meeting. And in prevention and health inequalities, it talks about developing an action plan, but says that we'll see delivery of demonstrable improvement in outcome based on secondary prevention within 12 months. And I'd probably just like to issue caution and reality there that many of the changes that we would want to implement, such as secondary preventions, looking at people having pulmonary rehab, stopping smoking, a whole range of things, which we discussed yesterday at the Health Inequality Prevention and Personalisation Board in quite a lot of detail, are there in our system and really to be celebrated and, yes, improved upon. But I think demonstrable outcome changes within 12 months, unless we mean sort of process change, will be quite difficult to prove. So I wouldn't like to set us up for a fall when there is some really good community embedded work going on. Thanks.
Thank you, Sarah. Mary or Simon, do you want to respond to that?
Just say that's a very good point, very well made, isn't it? And I did notice the wording of that, and we will challenge the wording of that, because I think it's a bit of a contradiction, isn't it? Secondary prevention that immediately demonstrates an improvement. That's not really what they're talking about. So I'm sure we'll have the opportunity to clarify that with colleagues. What this gives us is a chance to get a plan down on paper that captures all the work we're doing. Most of the work that we're doing around secondary prevention, the payback time is much longer than 12 months, Sarah, as you quite rightly point out.
And I think Will would probably like to come in on that. Will?
Yeah, I just to say that our prevention team have met with the regional team subsequently to the QRS, where that was asked of us to clarify that ask. So they are currently working on the paper at the moment to present back to them, but they have tried to clarify that already somewhat. But I completely agree with you, Sarah. We need to be cognizant of what we can achieve, but it's the right way to go, isn't it, in many ways?
Great. Thank you. Very helpful. And thanks, Simon, again, and colleagues who've helped Simon with that report, which was, as everyone said, is very comprehensive, and really good questions and comments from colleagues around the room. I suggest we're a little bit ahead of time, so I suggest we go on to the next item before we have a break. So the next sort of section we're moving to is system performance and risk, and we have a number of reports within that. Today we've brought forward our committee's highlight report on delegated responsibilities, because we felt it was always at the bottom of the agenda and it needed attention, because obviously we have got a number of committees in place who are acting on behalf of the board. So I'm going to bring in Hannah. Do you want to introduce it, or shall I go straight to the chairs?
You can go straight to the chairs, Krishni. I think actually, now that you have asked me, the only thing I would mention is that we have done some extensive committee effectiveness review, which is still in progress, and the kind of results are being analysed, and we will be bringing that back to the public board in July. So all the committees have been really active. Most of them have met, and yes, over to the chairs, really, Krishni. Thank you.
Okay. Thank you very much. So shall I just take that in turn? So Vicky first, please, for the Quality Committee or QRD.
Yeah, nothing to add to the paper. It's very comprehensive in terms of the balance of our conversations and where we're heading in terms of our direction, particularly the system focus. So happy to take any questions, but nothing to add to the paper.
Okay, thank you, Vicky. Did you want to draw out anything about the sort of participation of non-executives from the provider trust? Because I think that's been particularly positive.
Yes, I mean, that's been particularly helpful in our conversations to make sure that we don't duplicate and we distill all the conversations that have been had at provider level and across the system, and we discuss the remaining risks and actions that we can support across the system. The NEDs who've been attending QID have been extremely helpful, and I think it's important, as you note in the paper, that we're going to be amending the terms of reference to formally reflect that membership of the NEDs on the committee, because there's no doubt that the added benefit is significant.
Thank you very much, Vicky, and thank you to chairs for sort of accommodating that as well, because it's been a really positive development. Strategic Commissioning Committee, Sarah, anything you want to highlight?
Again, I think the report goes through our highlights. Probably just pick out, you can see we spent quite a bit of time discussing the fuller stock take and how that may be implemented locally, and I think, Krishna, you'll have more details, but I believe we've got Claire Fuller talking to us as an integrated care board as an integrated care system in the near future. So that will only serve to develop those plans further.
Thank you very much, Sarah. I'll pause there. Were there any questions on either of those two committees' reports? Okay, I'll bring in the other chairs and then I'll pause again. So, Mary, anything to highlight from the Operational Executive Committee?
No, nothing in addition to the report to add today.
Okay, thank you. Audit Committee, I think Graham particularly wanted to come in on something today, and I'll also offer the opportunity, Graham.
Yeah, thank you, Krishni. Yeah, I just wanted to give the board an update on the external auditors, which we have talked about before, of course, because the audit committee looks at all of the different systems of assurance, and an important one for the public in that is the audit of the financial accounts. As we've talked about before, Grant Thornton did resign at the end of 21-22. And the non-executive members, along with the executive team, have gone through procurement unsuccessfully to get an expression of interest. So we have been working in conjunction with NHS England and have identified a provider for 2022-2023. And that work is likely to commence now for December 2023, with the audits of 23-24 starting in May 24. All of that's been done in conjunction with NHS England and is all agreed. So an update, Krishni.
Thank you very much, Graham. I've got a question from Jane.
Yeah, I mean, it might be too much detail, but just reading the report on the local security management update, and I'm just not quite sure how that sort of fits in with things, because obviously as organisations we have this service and have a responsibility to make sure that we keep patients and staff safe. I'm not quite sure from an ICB point of view how this fits in, because it doesn't feel like an ICB issue. It feels very organisational specific, and so I don't know what an action plan would look like for the ICB.
Thank you, Jane. I think Hannah wants to come in. Hannah?
Yeah, thank you. So I can answer that. So you are right, Jane. It's largely kind of a provider issue. I think where it is relevant to ICBs, if it's services like continuing healthcare. So we do have a team that goes out and talks to patients. We also have got issues in terms of patients actually calling the front desk. So some of the issues relating to ICB are limited, but we still need to be, obviously we've got our buildings, we've got our estates. So there are some issues specifically relevant to ICB. I think local security management is one of those areas where ICBs are trying to find their feet, similar to, for example, freedom to speak up, or some other kind of compliance areas where NHS England are kind of trying to decide at the moment what role ICBs are playing as a system and bringing things together. Probably less of a role in local security management, but there are some very specific actions that relate to ICB, because obviously some of our stuff are patients facing as well.
I mean, it does feel like it's a place where we've got opportunity to merge some back office functions, doesn't it?
Absolutely.
Yeah.
Absolutely.
Yeah. Very helpful. Thank you, Jane. And that recommendation or suggestion, I think we should note and consider. OK, Aman, did you want to add anything to that report back on the audit committee?
No, Krishni, I think Graham's covered all of the points that needed to be made. Thank you.
OK, thank you very much. We also had the inaugural meeting of the Mental Health Collaborative, which is reported in there. And I think Sarah Raystrick as Vice Chair chaired that. Sarah, anything you want to comment on?
Oh, I attended that, and we've had a second meeting since then. First was very much scene setting, and it does seem as if this is going to be a very positive and effective committee. So early days, but so far good. Thank you.
Great, thank you. Are there any other comments or questions regarding that report, or anything, Hannah, you want to add? No? OK. Hannah?
No. Thank you. Okay. Sorry, Krishni. I was just going to say that development that we have introduced in the committee report linking to the risks. So something that we're hoping going to be helpful in terms of triangulation and cross-referencing with some of the risks that the board is overseeing.
Great. Thank you very much. I suggest, so we are running a little bit ahead of time, but we have got a big chunky item coming in the deep dive for people and workforce. So I suggest we have a short break now for, let's say, 10 minutes. And if we could mute and turn our cameras off, but be back at 10:35, please, and then we'll start with the deep dive. OK, thank you.
can definitely see you now, Vicky. I can't hear you, but
That's just really weird because I was struggling to get the background because there's two different versions of Teams. And so I went out, came back in again, had the background, and then you, but I could see me, so I didn't think there was any problems.
well, I was wondering whether you just turned your camera off, and then
No.
maybe forgot to turn it on when you were talking. But yeah, no, strange. Yeah, so I wasn't
Really
sure, but it's
weird.
all fine. It's all good.
So apologies.
No, don't worry. Apparently, Tom was telling me that the YouTube, the live stream view has changed. Before you could only see the person who's talking, and now you can see everybody. So that's probably worth bearing in mind as well, that everyone is kind of being broadcast, not just the person who's talking.
Okay, welcome back, everybody. So we're moving on then to our deep dive on today's agenda, which is people and workforce. Katie has produced a very comprehensive report. Thank you, Katie. I don't know how you want to play it. Do you want to maybe highlight a few key things, take the report as read, but if there are sort of specific things you want to pause on, specific themes you want to pause on, we can perhaps bring people in for comments and questions at that time. So over to you, Katie.
Thank you, Chair. Hello, everybody. Yeah, thank you for the opportunity to bring a deep dive into people and workforce. It's clearly a huge topic across the entire system. And since I've been here a year now, it's what I've heard as a sort of the key set of risks are around workforce in pretty much everything that we're talking about. So I relish the opportunity to talk you through some of what we've got in place, some of what we are finding, and where we think we need to go next. So the paper, which, as you say, Chair, everybody has, gives you a bit of a pen picture, first of all, about the workforce across the system. It outlines some of the key risks to the people and workforce work. And there's a specific point I'll want to pull out as I go through about how that links to operational risk across the system. It provides a bit of an outline of ongoing work that we're doing to address some of these risks, and then where we want to go next. I won't obviously go through all of the detail, but I will pull out in the first line. We've got a workforce of around 40,000 people, and that doesn't include the VCSE sector, the voluntary and social, voluntary and community sector. There is some workforce planning work going on in that sector to understand how many more people we've got, but we've got at least 40,000, and that equates to at least 5% of our overall population. So our role as anchor institutions is very clear when you look at that data. I break down then where we've got some of the issues. Both in social care and secondary care, these issues are national, well, in primary care too, actually, but the issues are national. We've got big vacancy factors for our care workers in social care, with some of the big issues being around the workforce choosing to work elsewhere. Retail is often cited as a competitor for our workforce. So we've got 2,000 unfilled roles in our system in social care. Our primary care workforce is at the moment in not too bad a shape, but we do have a bit of a cliff edge with our nurses. As we know, we've got one of the best GP ratios in the country to patient numbers across Herefordshire and Worcestershire. So at the moment in primary care, it's about understanding where some of those risks are coming and mitigating them as much as possible. We do have quite a few GPs in training. A large percentage of those are international recruits, and the numbers in training has increased over the last few years. In secondary care, we've closed the gap quite a little bit since this time last year. So we have overtaken turnover slightly and managed to have an extra 350 across the secondary care providers. The big issues, as we all know, are in nursing and specialist medical roles. Nursing vacancies tend to link to the national supply of nursing issues, which is linked to the availability of bursaries for nurses. We do find it really helpful having the University of Worcester in our patch, because we have some really close conversations with them about nursing and the nursing and midwifery school and how many people we can retain across the system. We have about 50 to 60% of the nurses that go through who stay in the system, which is actually quite high, although we're looking at what we can do to retain more. We've talked a bit about international recruitment because the staff story was about an internationally recruited nurse, but this is our kind of mid-term approach really to filling some of those gaps, particularly for nursing. And this year we'll be looking at bringing in another 250 nurses, so 150 in Worcester Acute, 100 in Wye Valley, and we're going to see if we can do more with mental health. Typically you can't get so many international nurses for mental health nursing, but we are looking at what else is doable. We go on to a bit about staff experience, and you've got a pack of some of the NHS data. I don't have all the data for across the system yet on this, and I'm working with colleagues in the local authorities and in the VCC and PCNs to see what else we have, so we can tell more of a picture. I suppose the headline here is we're pretty much in the middle of the pack for the NHS. The RES and DES data, that's the race equality and disability equality data, doesn't show a particularly different picture for us, but it does show a picture that we do want to correct. So our overall population data in the 2021 census talks about Herefordshire having 3% and Worcestershire having 7% of people from a Black, Asian, minority ethnic background. The ICB and Health and Care Trust represent that, and then in the acute trusts we have more representation. But we do know that people from those backgrounds and people who identify as having a disability do tend to experience more issues around bullying and harassment, and that's something we're looking at together across the system through our EDI work. When you look at our staff survey results, and again, these are just the NHS at the moment, we're trying to build the picture across the system. We do hear common themes, and these are themes that we know system partners experience as well, because we've talked about it. People talking about being understaffed, time pressures, a lot of this coming from vacancies, and then a very low percentage on satisfaction with pay, which is not surprising given what we've seen around industrial action and the agenda for change conversations that are going on at the moment. But we do have around 79% that feel their work is valued, and there is still that really clear moral core about doing caring work that comes through in the staff survey results. I'll come on to risk. Clearly, there are workforce risks in a lot of different programmes that we run. So we've not listed all of those here because we're doing a piece of deep dive work at the moment, looking at the systems, programmes and where we think the workforce risks are. Because these people use workforce interchangeably to cover a whole host of people-related issues, from recruitment and supply issues through to even personality clashes within teams. So we're trying to understand what each of the risk issues are for each of our programmes, and we're going through a process with that at the moment. But in terms of the overall sort of very high level risks, workforce supply clearly is an issue, but particularly in those nursing and medical and care worker roles. And so a lot of what we've put in place so far is to try and help to mitigate some of those things. And then when we get an understanding of the risk by programme, we're going to try and do some more detailed work to then address some of those programme by programme, if you like. The other one I would draw out is the vacancy and this cycle of having a vacancy and using agency staff to fill it. We could dedicate an entire day to talking about the use of agency, the reasons behind it, and they're multifaceted. It's an issue for the whole of the NHS and somewhere where we've got a big drive to try and bring down agency usage. But we do know that this system uses a lot of agency. We've got a lot of data for the NHS, less again for care homes, care providers and primary care, because they're independent organisations predominantly, and they capture that data themselves, but we don't necessarily have it as a strategic level. But the other point I pull out on agency expenditure is it's not just a financial issue, even though it is a big contributor to our financial deficit. It is also a quality issue, because one doesn't get the same level of consistency from a member of agency staff that one gets when they're substantive staff. So we're very conscious of that fact, and there is a huge amount of work going on to try and address that, and we will almost certainly come on to it. I'll then go on to, I can see 2 hands have gone up. Would you like me to pause and wait?
Yes, let's do that, Katie, in case there were specific things from comments you've already made. So Russell first, please.
I was just going to make some comments at the end, Krishna. I don't want to interrupt his flow, because she may mention points that I'm about to make. So I wouldn't want to.
You're just putting your ask for being first in the queue then. No, that's fine. Thank you. Anita, was there something specific about something Katie's already covered?
Kind of, although I suspect it might be also one of these that could put at the end. I mean, first of all, just say really like to see this paper, and I think it's very comprehensive, and you cover a lot of the areas, so I think thank you for that. Colleagues might be interested to know, we actually at Worcestershire Acute actually ran yesterday a day dedicated to wellbeing matters, both health and physical and mental health. And clearly it was about staff wellbeing, but it was also about, obviously, leads to issues around retention, recruitment, etc., etc. And I think that speaks to some of the points that Katie was sort of alluding to in terms of you know, our obvious understanding of our bank and agency issue in this system. Some really good input, and we actually had Milton Keynes were there as a speaker, and I think some of you will know Milton Keynes are doing some of the most innovative work around strategies to improve retention and therefore reduce their bank and agency, and that was brilliant. What was really came out of that, however, was the fact that a large part of their success is about the fact that they have been willing to invest in things in order to improve the staff experience, in order to reduce the bank and agency. And they've been doing this for 3 or 4 years, and they can demonstrate an ROI there, although it's taken a while. Things like providing free tea and coffee, or free parking, or a hot meal for staff at £2 a day, or all sorts of stuff that they're doing. And I guess, given we understand, for all the reasons Katie's just said, both for patient, the quality of care and the financials, that this whole thing about bank and agency is a really big deal. But we also understand our financial constraints. I'm wondering whether we have a sense in this system of our appetite for recognising that we might have to spend a little in order to save a lot. So just interested in people's thoughts on that. Thanks.
Thank you, Anita. Shall I let Katie just pick up on that and then continue, and then we can throw that into the conversation. Katie?
Yeah, thank you. I completely agree. I feel we've got some retention work that's going on at system level, but it's very hard to do it at system level when it's the what I call the hygiene factors. So a lot of those will be done at base, because fundamentally the reasons people stay in an organisation because they have a good relationship with their line manager, they feel valued and looked after, and some of those things that just are really annoying if they're not in place, or cost them a lot of money, or take a lot of their time, that only the local establishment can deal with, are the things that make people decide to stay or go. So a lot of retention is done very locally, and I think the point you raise about it's the big system questions that we should be asking ourselves about where we want to invest to save for our people, that we as a board probably need to be talking about. And as I go through, I will just talk a little bit more about that, and I think Jane's got some views on this as well.
Jane, are you happy to wait until the end, or did you want to come in now?
No, I'll wait till the end. Thanks, Katie.
Thank you. Yeah, so I mentioned agency usage there, and I think clearly we'll have a bit more of a conversation about that. The other point I'd make is around, I've called it change resistance in the paper. It's probably not quite the right title, but what I've found as we've gone round and talked to people about, well, what is your workforce issue here? We've ended up doing quite a few STAR workshops. So this is a workforce planning framework where we take groups of people together and talk through what some of the workforce issues are. And very often when we go through that process, we realise that we're not going to massively be able to change the supply, because as I've mentioned, a lot of these issues are national, and we are going to need to do more transformation of services. And I think recognising that fact and not allowing workforce to always be the backstop risk is going to be really important as we progress. So looking at public health data, understanding what we need to do in the future, and then fitting our workforce to how we're going to work differently, using a lot more digital tools as well, I think will be really important. So I'll just say a little bit about the system approach. Already we're starting to pull out, I think, that a lot of the local recruitment retention stuff happens at an organisational level. And so the real challenge for the system is understanding what we can do better together. What can we do that doesn't duplicate effort, that spreads best practice, or that can only be done because we pool our resources or we pool our buying power. So we're trying, that's really what we're trying to focus in on. And I don't pretend for one moment we fully got that right yet. We've got a people infrastructure in place that I feel can have quite a lot of clout now, but it hasn't quite yet got to the 5 or 6 things that only the system can do. And I really want us to focus in on that over the coming months. It's worth saying that there are varying sizes of HR teams across the system. So our big organisations will all have quite a large HR team doing some of this. But if we get out to some of the social care providers, often they're doing the bare minimum when it comes to HR. They're probably just doing some compliance. And some of this is outsourced. So we're dealing with quite a breadth. And it's easy to lose sight of that, I think, from a system perspective when you sit in one of the big organisations like the NHS. So trying to have representation from across the system and understanding the full range of challenges is something we spent a bit of time on. The other thing to mention here is we know that there's going to be a lot more focus on bringing enabling functions together, and that's got to be part of the solution for helping our system in a deficit position. So we're starting to have conversations about what are some of the HR functions that could be done better together. So not just spreading best practice, but actually doing the thing together. So we've got a programme plan. This has been built through huge amounts of engagement across the system. It fundamentally does follow work around attraction, retention, workforce planning, EDI, but it does try and do the things that are hard to do individually. So in attraction, it's about growing the pool. We're all fishing in the same pool, but we want to try and grow it, attract more people. And we can do at a system level more of that work to go out and talk about careers in the health and care sector than any one organisation can easily do, given the capacity. So a lot of, we've got a plan now for outreach and recruitment fairs, and working closely with further and higher education to try and help bring more people into the pool and choosing health and social care as a career. And quite a bit of work looking at our apprenticeships as well, and how we can use those to help to attract and retain. I've mentioned retention. It is hard to do it at a system level. The things we've landed on at the moment are occupational health, because we know that that's something everybody's trying to do. It could be done better together. We could have one provision, so we're looking at how we do that at the moment. Linked to that is how we do wellbeing together. We do have the wellbeing hub in the Health and Care Trust at the moment. That is centrally funded, but that funding will end at some point. We do want to still be able to direct staff to the best provision that we can, and as quickly as we can, even if it doesn't look quite the same as it does right now. And talent and leadership is the thing that's come up as an area that everybody wants help with, making sure that there's the right tools in place, leadership training, career conversation tools. These are not things that people can easily put together overnight, and a lot of people are asking for them. So we're putting some of that together at the moment, and providing some better signposting to some of the other training that's out there. I won't go through everything in this list. On workforce planning, I will say we're trying to build more capability. It's an area that people don't necessarily always feel confident in. Everybody does workforce planning most of the time. They're talking about how to staff their wards or what they're going to need in the next few weeks. We probably don't do it as confidently or as strategically as we might. And that's the bit we're trying to pull together. And then we're doing some specific work with fragile services. So when we spot a fragile service, sending in people who can take us through a framework and pull out what some of the short and long term issues are. And I'm going to be doing that in a more systematic way through all of our programmes, as I mentioned earlier. There's lots of work through our faculties. So we've set up a virtual one-stop people shop, if you like, which is called the ICS Academy. It is twofold, its purpose. It brings together different functional groups to talk through issues pertaining to that functional group. So there's one for allied health professionals, for example, there's one for pharmacy, there's one for medics, there's one for nurses, there's one for VCSE, there's one for social care. And they come together and talk about what do we need to do for our function, and that's overseen by a steering group which is chaired by Professor Sally Moyle at Worcester Uni. And then we've got some EDI work that's mentioned there. I won't go through that in greater depth, but maybe we'll pull out some of the points given the data we've seen about res and des. The governance, I think, is fairly clear in terms of how it's set up. I'm not sure all of it's working quite as I want it to yet. The sort of central part of it is the people board, where we bring together representation from across the whole system and govern the overall programme. The assurance element of it isn't as strong as I would like. It's very good for bringing people together, and there's a lot of will to do work together there. But we need to do a little bit more with the oversight and governance of the 3 work streams that sit beneath it, and bring through more assurance that the academy faculties are doing what they need to do to help us with workforce planning. So I'm going to be tightening that up over the coming months. And then we also have the People and Workforce Forum, which is much more of a senior leadership engagement area where we bring together big strategic issues that are preventing us from doing recruitment, attraction, retention of staff. So for example, we will be talking about agency spend at the next one. The one after that, we'll be talking about housing and its limiting factor for recruitment. So What next? I think we've got some good infrastructure in place. We've got some really good groups working together. We've got a few projects underway, and I think we're proving that working together is creating some good conversations, good solutions. It's tailoring that now to the operational realities that we're all facing by getting into the real detail of those programs, and it's making sure that the assurance then provides us with, this is the issue, we're going to target it in this way using the infrastructure, and this is how we're going to, these are the outcomes that we're hoping to see, and making sure that we can then provide that assurance back to the board. So I think that's probably enough from me. I really welcome your insights, your guidance, your steers on where you see us needing to go next, and I'll throw it open. Thank you, Chair.
Thank you very much, Katie. Really, really comprehensive review. And I think the plan that you referenced, I think a copy of that was included with the papers, wasn't it? So people could see what sort of actions were being taken forward. OK, so I think we have a lot of people wanting to comment. And so first of all, Russell, please.
Thank you, Chair. And just to say something I said earlier, I'm very assured, Katie, that you are leading this work, because I think you're getting into the right level of detail, pushing a real practical focus and trying to make things happen at pace. So my comments are just supportive but just making a few observations. The first is retention's always easier than recruitment in any workforce issue. So we need to do a better job at retaining our staff and understanding why we lose so many staff. And I don't think we do have enough knowledge at the moment. Our exit interview numbers, in my view, are very poor. We need to do a much better job at getting behind what people are saying as to the reasons they're leaving. When people join the NHS, Katie heard me say this the other day, it is generally a career for life decision. So if they're moving within the NHS, let's understand where they're moving to and why. Partly goes back to Anita's point. If they're leaving the NHS and they're going to agency, why? Or if they're going to the private sector, why? At the moment, we do too few exit interviews, and those we do provide too little data. They're poorly executed. And I'm making this point as much about my own organisation as others. The third point for me is, and you haven't mentioned it, Katie, but for me, it's the elephant in the room. Pensions are undervalued in the NHS. The employer contribution on pensions in the NHS is extraordinarily high compared to the private sector. So if you do want to go and work at McDonald's or in retailing, you will get at most about 3 or 4% of your pay as an employer contribution. If you go and work in the private sector for Spire or Nuffield, it will be similar. It might go up to 5%. Certainly if you're working in social care, it will be down at 2 or 3%. In the NHS, it's 20%. Now, we're incurring the burden of that cost, but not seeing any of the real benefits, because we don't talk about how great the pension is. And it's always been a bit of a mystery to me, and as a non-exec, I don't get an NHS pension, just for public knowledge, nor do any of the NETs who work in the NHS. It's always been a bit of a mystery for me why we don't talk more about the wonderful pension that is offered. Because if it's not valued, then that should throw up different options. But if people are unaware of it, we should be talking about it. So the whole focus and lack of communications on pensions, I find very, very odd. My fourth point would be we need to, all of us, need to stop scoring own goals. So, for example, my definition of an own goal is it takes too long often to get a recruitment offer out. The time to recruit often is far too long. That is within our power to address. The second is ensuring we're using best-in-class retire and return processes, so that if people understandably want to retire because it's such a wonderful pension, let's get them back. Everyone needs a purpose in life. If you've joined the NHS, it's because you're a caring, kind person who wants a purpose to help others. So let's help those who retire to come back. And the final point would be some of the hygiene factors. For example, car parking. I hear quite often from people who work in our system that they have to arrive at least half an hour to 45 minutes before their shift to find a staff car parking space. And it takes them off for 45 minutes to get out of the staff car park at the end of their shift. Those type of hygiene factors are very real if you're a working mum, or you've got working father, or you've got pressures at home and you need to get home. Those become really disproportionately practical issues, which should be in our control. And I'd like to hear more about those. My final point is, and Katie touched on it, our big two financial opportunities this year are driving productivity and the variability of performance that exists in our system on productivity. And the second is reducing agency. So this isn't just a workforce issue, as Katie quite rightly said, it's a finance issue as well. If we don't reduce agency, we haven't got a cat in hell's chance of achieving our financial plan. So the work we're doing on agency is financially disproportionately important. Sorry to be so long-winded.
Thank you, Russell. Katie, was there anything, I mean, clearly there was a lot of points there. Was there anything specific you wanted to pick up on? Or are you happy just to take other comments at this stage?
I would just say a couple of things. So I agree with all of those points, and Russell and I have spoken on it before. The exit interview work, about 30%, we've got about 30% exit interviews. So we are looking at how we can drive that up, because that is where we'll get the intelligence. But we'd like to do more predictive work as well. So I'm going to look at how we can do that, because there are ways of predicting when people will leave. Pensions and advertising that fact much more, that will come out more in our outreach work. Whether that will attract people through further education and in schools in quite the same way, I'm not sure. The problem with the cost of living crisis is that people are tending to pick today's pay packet versus the future career development or pensions. But I absolutely accept the point, and we need to do much more on advertising what a great benefit that is in the NHS, but that's not true, as you say, of the whole system. So we need to just be a bit careful about thinking about the system approach to that. But I will leave it there, because I'm sure we'll pick up with some of the other points as we go through, Chair.
Thank you, Katie. Right, so there's quite a queue, Katie. So we'll sort of, it might not be easy for you to comment on them all, but we'll just perhaps pick out one or two as we go along. So first for Jane.
And Katie and I have had a number of conversations in the last couple of weeks, which have revolved around two things really. One is, this is a massive agenda, and I guess I've got an anxiety that we need to focus on a few strategic things, and we can't do a fantastic job on absolutely everything, and we have to get the balance right. And I know, and I think your comments, Katie, on what we get right at organisation, place and system levels are absolutely right. And yeah, there's lots more work to be done, but I think, you know, everybody's heart's in absolutely the right place with this, that we want to do things at the right place and make a difference. But I think in terms of that, so what is the biggest priority? And for me, it's around the things that we can really make a difference to locally. So if we look at our medical staff issue, you know, it takes 15, 20 years to train a consultant, and Worcester University only gets a medical school from this year. We're not going to be able to fix a lot of that locally. There's all of those other sort of hygiene factors, things that we can do, but we're not going to be able to fix the strategic problem locally. But I do think we can fix the strategic problem around nursing locally with a grow our own strategy. So we've been doing a lot of work on that, and I've talked previously about our healthcare assistant offer and that band 2, band 3 offer, making that career progression different, and there is some pay impact on that. But we've been at this for just over a year, and we've dropped our healthcare vacancies from 75 down to 10. And we've reduced our turnover. So there are things that we can do. Now, it means that our baseline costs will be a bit higher. If everybody was fully recruited, we would have more band 3s and less band 2s, but everybody isn't fully recruited, and it means that we're going to be using very few agency healthcare assistants. So I think there are things we can do. The next section then is around registered nurses, and we can train an awful lot of those locally. So the work that we've been looking at, and it's just coming to fruition. I know Katie's got a meeting with the CNOs this afternoon, so we'll be getting some more of the detail on this. But broadly, to look at our skill mix, to have more band 6s, more band 4s, and less band 5s, and that being our grow our own strategy for registered nurses for Wye Valley. Broadly, that's going to cost us probably £400,000 a year for the next 2 years. And in 2 years' time, we could have fixed that problem. So I think there are some really big strategic things that we could do, but it means we're going to have to do less of other things, because if we're going to do that, we can't afford to do some other things. And but I guess that for me in all of this, and there's some absolutely brilliant work here. I think the comment that you make in your section on the tension between the need for long-term funding to create our grow our own strategy and the limited funding position that we've got available, I think that's at the core of this. And I think we've got to agree what our priorities are so that we can fix the things that we've got the ability to fix internally.
Thank you, Jane. Katie, shall I just take a few more comments, and then you can perhaps make a more general comment across a range of things. Graham.
Yeah, thank you, Krishni. Yeah, Katie, very interesting. I was just interested, and put your mind forward a little bit of time, imagining that, forgive the term, left shift was very, very successful. Would that change at all the sorts of groups that we would be looking at, and would that change some of the policies in terms of the approach, in terms of recruitment and retention, and how we deal with possibly a different profile workforce?
Katie, do you want to come in on that, and anything you want to pick up from Jane?
Absolutely. So first of all, I agree wholeheartedly with what Jane has said, and I do think that grow your own nurse strategy has to be one of the key things we go at. I also think medical placements is the other key thing to go at, so that as the medical school does get up and running, we are there taking in the supply and finding the places for people, because these are just, these are two very open possibilities for us, and we need to seize them. And I do think that's where we'll start to target our work down. Actually, I think some of these programs might fall away as we manage to get to those priorities, and I want us to do that. Graham, your question is absolutely the right one in terms of how do we move from big broad programs to taking a pathway or a service and looking at how we do it differently, changing the service delivery and changing the workforce to match. And what I'd like to see is, as we start to have conversations about which of those pathways we do work on to left shift or to move more to prevention, if we use slightly different vernacular, I want to see multidisciplinary teams that include workforce and digital teams around those conversations, so we can help to think about these things differently. We can use the faculties and the functional groups to think about clinically how you might do things a bit differently, and then we can work with the university to start to deliver different curricula to enable us to grow that workforce for that new service. That's how I envisage it working, and I think what you might see in a year's time is more of a breakdown by the types of pathways that we're taking through a left shift process and what we're doing for each of those pathways and where we're seeing some of the things marry up, rather than probably a more holistic set of activities as you're seeing now. That's what I hope.
Thanks, Katie. I mean, it's a really good point, and I think the voluntary sector is a potential asset to us in the working differently. You know, what part can be demedicalised that can be done by the voluntary sector, a properly funded voluntary sector, as an asset to us, and what parts do we absolutely need to do. I think that's quite an interesting. Ought to be an interesting part of our thinking, really, using particularly as we move towards a more prevention focused model. Sarah Dugan.
Thank you. Thanks, Katie. It was a really great report, and it shows how much work's going on behind the scenes across a whole range of areas to do with workforce. But my question was really about shared opportunity and understanding where we focus our energy, a little bit like Jane's. But there are loads of shared opportunities, aren't there, in here? And things like international recruitment work has been fantastic, and we certainly have learnt a lot from people who've gone earlier on that programme. So my question, Katie, was more about how we're approaching evaluation. Obviously, there's an evidence base, but actually what I find sometimes in workforces, we're so keen to fill the vacancies, quite rightly so, that we try lots of things at once, and then we're never really clear which ones made the biggest difference. And I do think it's something as a system we could do more of, really understanding, evaluating each of these new initiatives and which ones really work, and then rolling them out really quickly when they work. So I'm just interested in your thoughts on how we approach that.
Thank you. We're trying to build up much more data on some of those things at the moment. We've got a dashboard that we're building, which at the moment brings together organisational data, but I want to build it further so that it tells us what's working at system level and where we're seeing shifts, and we can start to do some of that evaluation. I mean, each thing has its own set of metrics from the programme plan. So behind the scenes, we've got a list of, you know, what we're trying to achieve and a set of milestones, and we are going and trying to grow an assurance process that sits behind this, so we can look at, are we achieving those milestones, what impact has it had, and then a regular dashboard that shows whether we're filling vacancies, whether we're seeing improvements in skills, what the faculties are telling us. So a whole range of different information coming together. I would like to bring that here more regularly, if that would be okay, both in terms of the overall workforce dashboard and the agency work. Actually, I think exposure to what's going on there and constant kind of repointing where we need to go would be really helpful to us.
Thank you, Katie. I think that's a really good suggestion and opportunity for us to sort of keep the focus on this. So, so Katie, absolutely take that away, and we can think about how best we present that back into the board as a sort of a regular feature. David Whiteman.
Thanks, Krishni. Again, congratulations, Katie, on a great paper that, I mean, you can see from the questions coming out that this is really at the heart of what we do. I've got 5 brief points I'd like to make, not as many as Russell's 6, but only 5. First is, does this report overall paint a picture of a system workforce in crisis? Because we often talk about the crisis in workforce, and there are some positives coming out of here as well as some negatives. So that's my first kind of comment and question, and linked to that, number 2 would be, you do point out correctly that the workforce, or more workforce, is not always the answer to improving services. So, and you mentioned addressing the transformation of services. Is there anything that we should be doing to remove blockages to allow us to address the transformation of services more quickly? Because I think that will clearly be one of the longer term solutions. The third point would be, and we haven't mentioned whole-time equivalent GPs yet, because it's a little bit difficult for us as a system, but we do see, and your report points out, 13% decrease in whole-time equivalent GPs, which will have a knock-on effect. We're very proud of how our primary care operates in our 2 counties, but actually with that reduction, we're likely then to eventually see more pressure coming on secondary care. So is there anything that we can do as a system which actually will support the increase in a number of whole-time equivalent GPs? Fourth one, and you've mentioned it, is strong leadership. So are we saying now that the system will take a lead in terms of developing leadership programs so that we can increase the leadership cadre and leadership strength we have? Because that will be absolutely critical in the future. Organisations with strong leaders or strong leadership will always be more successful than ones without strong leadership. And the fifth one, also something you've touched on, but from a slightly different perspective, are our local HR teams actually strong enough? Certainly, we're talking about the back office integration. That must be part of an overall solution. But actually, do we have strong enough HR teams in place? And if not, then well, I'm not sure I can ask you what can we do about it, but it's a general comment that if it's not strong enough, we will need to focus and put extra resource there as well.
Thank you, David. I think there's quite a lot there, Katie.
Yep,
You
that's
want to
fine.
try and touch on a few of those that you can respond to?
Yes, so firstly, is this a system with a workforce in crisis? I think it depends on your perspective and where you're sitting in the system. So if you're in a haematology team, for example, you would say absolutely yes, because we are staffing some of our haematology with locums and we'd like to have a more sustainable workforce. So I think there are absolute pockets of crisis, some of which are national crisis in terms of workforce, or come from the national position, I should say. I don't think we've got huge amounts that are locally incurred, but I do agree with Russell's original point around there are areas where we're probably shooting ourselves in the foot, and we should be ironing those out and not doing that and doing everything in our power locally to attract and retain. So I don't think I can give you a kind of overarching yes or no to that, but I think it's one perspective. Nursing and medical roles and care roles do remain the areas where we feel quite nervous. I agree that more workforce isn't always the answer. The transformation work, I think, is where we go next. And I think some of the conversations we've been having about left shift, about the joint forward plan, about bringing people together and thinking about how we do some of these things at system level is where it will be at. And that's where we want to make sure workforce is really knotted into those conversations. So I think as we go forwards, that's the focus we need to be putting onto our work. On whole-time equivalent GPs, there's a lot of work to try and retain GPs, salaried GPs, and create more partners, because that's also an issue. There are a few people wishing to be partners. A lot of our GPs in training are international recruits, as I've mentioned, and we've been setting up the ability to sponsor those people to stay in the UK. So the primary care training hub's doing an awful lot of work to try and retain those people through sponsorship and making sure that those people are supported to go through their visa applications, etc., as they need to stay. So there's quite a lot of focus on it. I can bring back more to you if you'd like more detail around some of the programmes of work that underpin that. On strong leadership, I completely agree. It's essential to make sure that organisations are run well. Each organisation does have various leadership programmes for their staff. I think the bit we can do differently at system level is about the tone of system working. It's these sorts of conversations all the way through the organisations. And so we're piloting at the moment a senior leadership connect programme, which it brings together some senior leaders from across the system to work together and think about leading across boundaries, compassionate leadership, understanding things from others' perspectives, thinking about the strategic system issues that we face. And we've had a couple of those pilot sessions so far. It's going really well, and I think there's definitely a space for the system as a whole and the ICB as a whole to help lead some of that programme. But I think it will complement what organisations have in place rather than take over, as it were. And then in terms of HR capability, it's really varied. I mean, some of the HR capability that's is really, really good, and people want to tackle these issues and want to work together. It's fair to say we hold an HRD meeting for the NHS every Wednesday afternoon. It's always well attended. People are really open. They'll talk through the issues. But then you get out to smaller organisations who don't have that capability and don't therefore feel quite so represented. So it's trying to understand the consistency across the piece and where we need to help people to come on the journey with us, as it were, I think, rather than not quite having the strength where we need it.
Yeah, thank you.
Thank you, Katie. Okay, there's a few more, so I'll just bring in Aman and Sarah Raystrick next.
Thanks, Krishni. So Katie, just want to echo what everyone else has been saying, that it's a fantastic report and really informative. I just wanted to kind of build on Russell's point, and you've heard me say this before, around the retention piece, that we do need to get that right, because we run the risk of losing new recruits if we don't get the retention bit of the piece right. I agree also that we need to have some sort of prioritisation in terms of area of focus, otherwise we could be doing too many things and everyone will be spread far too thinly and we won't be able to achieve the outcomes that we want. But my question was more around the transformation piece, around whether we're actually looking at how we're doing things, looking at our processes, looking at where there's opportunities for streamlining, but also are we working with other systems where they're having similar challenges, and is there any learning or any sharing of best practice there as well, really? Thank you.
Thank you. I might ask Mary if she wants to say anything on this, because clearly there's lots of conversations about this across the various pathways. Shall I hand to you, Mary, on that one?
Thank you. Yeah, I'm going to use an example if that's okay, colleagues. So we're aware that haematology across our ICS was one of our most challenged at-risk services, came very close to not being able to deliver. Workforce driven, completely workforce driven. But when we've through the joint working across the ICS and working with our other partners around us, so I'm going to pick out Shrewsbury as the best example. Having them around the table in our planning for keeping our services safe, they described to us what they've done with their workforce and how they've changed the roles of their consultants, nurses, support workers, because they were never going to get enough consultants, the haematologists, and they've done what we call the skill mix and taken each task by task and who could do it and how could they do it, and have got themselves into a really, really strong position. So Will's going to carry on the work with says we're going to carry on the work with them to try and get that workforce approach into our system. So we are learning from others around us, and that's one of the examples. But I think there's much more we can do on learning from other areas.
Thank you, Aman. I think it is really important that we get this sort of, and the transformation piece is something we all have to work on together, isn't it? And make sure that we consider the people implications in all of that. So Sarah Raystrick, and then finally Nikki. So Sarah first.
Thanks. This probably builds a bit on the retention element and the national and working together with other systems, but I think it was on page 4, there's a comment there under unrealistic time pressures that says 35% of people across NHS trusts and ICB are often or always emotionally exhausted, and I just found that quite, I don't know if shocking's the right word, but it really resonated, and that's a huge amount of workforce, and that's got implications for quality of our delivery as well and patient care. And then linking that to, I think, the national and sort of more international evidence about sort of vicarious trauma and people having gone through COVID and seen some quite difficult things. We would expect the sort of mental health impacts of that for our staff to potentially start hitting 2 or 3 years after the traumatic incident. So it's really, are we cognizant of that, and do we have plans in place? Because otherwise our sickness and our leaving will obviously compound what you're already describing as a significant issue. Thanks.
Thank you. We're very cognizant of it. It comes out a lot in the conversations that we're in. And actually, interestingly, Worcester Council recently did an ethnography study on the impacts of COVID for various workforce members, and they brought that to the People Board a couple of months ago. And we went through it and we talked about how people are supporting on wellbeing initiatives. Every organisation has quite a lot of wellbeing activity underway, and as Anita referred to earlier, you know, a whole day spent yesterday with Worcester Acute talking through wellbeing approaches. So I believe there's a huge amount, I know there's a huge amount going on across the system that looks at this, and what we're now doing is going through the staff survey together and saying what else is there that we might do. I suspect that actually that is one of those things that is best done at local level, with the exception of the OH and the wellbeing work, which I do think there's a really good signposting opportunity for us there, and the career development and the kind of talent and potential development gives people hope for the future, and that's a really important part of wellbeing as well. So those elements I do think are the right system ones, but the really granular responses to the staff survey are generally held at the organisations, and I know they've got huge amounts of plans in place.
Thank you, Katie. So finally, we've got Nikki Berger. Nikki.
Thanks, Krishni. It was just to pick up on the point of the whole time equivalent GPs again, and just to provide some further information there. So as you've said, there's been a 13% reduction in the hold timers, but you've also got to remember we've discussed the rise in consultation rates that we're seeing in primary care. So you've got fewer people doing more consultations than ever. At the same time, those consultations are rising in complexity. I think that's contributing to the fatigue and then the risk of burnout. So you've got some policy advice really about how many consultations GPs should be seeing a day coming from the BMA. So probably in an average practice, a GP in a day will see maybe 32 to 40 patients. And the advice really is they should only be seeing 24. So if you factor that in on your whole time equivalent numbers, you're probably going to need 30% more GPs than you've got now. So that to me says it probably is bordering on a workforce in crisis, because you really don't have enough to be sustainable if you're 30% short, with the potential that the workforce now is seeing unsustainable numbers of patients. And in some practices, on a busy duty day, the duty doctor is going to be seeing more patients than that. So if your primary care, resilience, the whole system's relying on that to prevent knock-on pressures in the rest of the system, then we need a lot more GPs in the system than we've got now if they're going to be seeing safe numbers of patients a day in a sustainable way for the next 5 to 10 years. That needs to be factored in, I think, to the numbers.
Thank you, Nikki. Katie, do you want to make any comment on that? And more broadly, what support do you need from us? Is there anything that we need to do as a board to support the work that's going on the people agenda?
Thank you, Chair. I'll note the points that Nikki makes. I mean, I agree. It's not, we're not totally in good planning for, and I know that Linda's got a lot of work underway to make sure that we have the right workforce support across primary care, and these are some of the conversations that are being had. More broadly for the board, I think that conversation around where are we prepared to spend to invest in staff to make sure that we have a long-term sustainable workforce is the really crucial conversation. I suspect we might soon want to bring something on nurses and supporting more to become qualified nurses. I think there are lots of other workforce supply groups that we will need to look at as well. So social care. Social workers is probably one as well. We know that's coming. Pharmacy is probably another. So I think there'll be some conversations that we will need to have collectively about how we get ahead of the curve in a very difficult financial position, and that'll be the challenge for us collectively, I think.
Thank you, Katie. I mean, that sounds like a discussion we could usefully have in one of our workshops. So perhaps that's something we can take forward in that way, and we can plan that in. And David's Mentimeter might have to come into play. But thank you very much, Katie. I mean, I think that was really comprehensive. So obviously sparked a lot of comment and discussion, and I think people have made a huge number of points, which I won't try and summarise, other than to say I think there's a really key sense that we need to prioritise our focus so that we're not spreading ourselves too thinly. I think there's some leadership from us needed to support Katie and HR colleagues, because we should collectively own the people agenda. It's not something that we should be just sort of leaving to our CPOs, I guess. So I think that's a really important point for me. But I think more generally, if I just say that I always go back, my recollection when the original NHS People Plan was introduced for the first time across the whole of the NHS, its ambition was more people working differently in a compassionate and inclusive culture. And I always go back to that, because I think that the risk is we focus on the more people, not enough on the working differently and not enough on the compassionate and inclusive culture which retains those people. So we've got to have a balanced approach across all three of those, and the working differently piece is so much more than, you know, it's about transformation, as we've said, it's about pathways, it's about digital, it's about all those enablers that help us to work different. It's about using the VCSE. It's all of those things that I think we have a really great opportunity working together as an ICS to think in differently in those ways. So thank you, huge amount of work. Thank you to all our colleagues who are involved in that and leading those initiatives. And I think we should take forward that conversation, Katie, and we'll need to think about how we build that in to one of our workshop sessions, so we can have a bit more of a discussion on that. Is that okay? Anything finally to add, Katie?
Perfect, thank you. Well, a big thank you to the 40,000 people plus who work across our system doing what they do every day. Without them, we wouldn't be able to deliver the right care for patients and residents. So I would just end on that. Thank you.
Thank you very much, Katie. I think that's a really important point, and I'm sure one we would all acknowledge. Okay, so we've done our deep dive on people and workforce. We have a few more agenda items we should move on to. So we have a system quality and delivery report, which Mary and Kath are sharing. Mary, is there anything that you particularly want to highlight in the first instance?
No, thank you, Chair. So, I mean, the report speaks for itself, really. I think there's a couple of key things to highlight to us. I mean, I think this follows on from this very helpful discussion around workforce. A lot of the risks that are identified in our Quality Resources Delivery Committee directly relate to the workforce and the recovery of services post-COVID. We're still very much in that phase. So whilst we do very large deep dives into all of these services at our Quality Resources Delivery Committee, this is just an overview of the key risks and where nationally and regionally we pay a lot of attention. So urgent and emergency care, I mean, the report outlines our current position. There has been some improvement from the very difficult days in December across our system, but we're still a system that has long ambulance delays and lost ambulance hours. And we provided some benchmarking against the standards that we need to achieve by the end of this financial year, just to show you where we are. Our ICS Urgent Care Board will oversee the improvement plans across our system, aiming to achieve that. But just to highlight to you that our ICS has now been deemed to be a Tier 2 system for urgent and emergency care. And apologies, the reason for being late to board was I was on the national meeting describing that. So I will brief out to you all in an email as soon as I can all the details of what Tier 2 system means across the country. But so urgent care, we have, I believe Simon has outlined the Ian Sturgis work in his report earlier on in the meeting, so I won't go into the detail of that. The only other aspect that I want to pick up from a Worcestershire point of view, is a couple of aspects, is the new A&E department is due to be opened in October, fully functional, and we've been requested nationally to have key lines of inquiry and get greater assurance as an ICS that we will see some of the benefits that are planned as part of that development. Positive note, Worcester Acute has now no longer inadequate in CQC terms for urgent care. It requires improvement, which I'm sure for the staff and the patients is a really welcome move forward. And I'd just like to highlight some of the work, the best practice work that's going on across the ICS. The Home Before Lunch campaign that I've spoken about before is really well underway at the moment. I did listen into the meeting across the ICS and shows the benefit of true system working, talking with the public, patients and our staff about why can't we do this? Why can't we get patients home earlier in the day? And it's bringing out some key areas of transformation improvement that we need to make. That's urgent care. I just want to highlight elective care to you. So we know our target of achieving 78 weeks zero, in the post-recovery period. We were unable to meet that at the end of March. Now the next target is the end of Q1, which is the end of June this year. Still a challenging target for us all, but there is an even more enhanced plan with more capacity come online. Indeed, pleasingly, in the last couple of weeks, we've seen a prediction where we're roughly in Worcestershire about 100 patients that are at risk at the end of Q1, and in Herefordshire we've got about 50 to 60 patients now at risk, but that's changing every day, so we are working very hard as a system to bring those numbers down. Pleasingly for cancer, we're doing really well on the front end of the cancer pathway. You can see in the report our faster diagnosis standard and our 2-week waits. That's brilliant for our patients and must be good for our staff as well. That's working really well. As a result of that, we now have some long waited patients for treatment, and the complete focus on that at the moment to reduce those long waiters and hit that target that you can see in the report that we need to hit by the end of the financial year. It's largely in one tumour pathway, and we're working with regional colleagues to try and address that for our system and our patients as well. So that's a brief overview of the whole report. A lot of detail and assurance done at the Quality Resources Delivery Committee, and happy to take any questions. Krishna.
Thank you, Mary. And Kath, before I bring others in, Kath, was there anything you wanted to comment on?
No, there's nothing further to add for me. Obviously, Mary's really highlighted the processes that we're working in it. So it's reviewing those programme boards, making sure we're getting the quality and delivery really working hand in glove together. So Mary's presented a really comprehensive view there. Thank you.
Thank you, Kath. So any comments or questions on the quality and delivery report? Okay, I think only really to reinforce, certainly in conversations with Region, it is really clear that we are, really expected to drive this elimination of 78-week waiters numbers, and certainly, at every conversation that I've had with Region, that requirement is reinforced. So I do think, obviously we're working very hard on that, but the drive to get to zero is seen as a very, very important target for all systems, and we obviously therefore don't want to be an outlier, which I think there is a little bit of a worry that we might be, but I know everyone's working really hard on that, so it's important that we support you, Mary, and all the colleagues in the trust to address that. Okay, if there are no comments, then we move on then to the financial plan and delivery for 23-24. So over to you, Mark.
Thank you, Krishni. So the paper today then covers two aspects. One, just closing down the old financial year, so 22-23, and then I'm just updating the board in relation to where we finished from a planning perspective for 23-24. So if I start with the old financial year, we collectively had a plan of 14.8 million deficit for 22-23. All year we've been forecasting delivery of that. We had a number of risks, a number of challenges, but I'm pleased to report that, subject to audits, the system finished with an outturn of £14.6 million deficit, and you can see the delivery by organisation within the paper. So I suppose firstly it's to say we delivered as planned, so we delivered the number that we planned at the start of the year. But just to pull out then within that, and we've covered some of the challenges and the reasons why. The agency spend was significantly high within 22-23. So we finished with spend of just under £76 million against an agency cap nationally set to 49 million. So a significant spend in agency. And again, the workforce conversation just was really good in terms of understanding some of the reasons why we're seeing agency at the levels we are. But then also our efficiency plans. So we had £50 million worth of efficiency plans. You'll see within the paper that we didn't deliver all of those efficiency plans as set out, and those that we did deliver, there was a big chunk of those that were non-recurrent. So whilst the non-recurrent is helpful, it helps the delivery in year, it doesn't help our underlying position as we go then into 23-24. So in terms of being able to deliver the position, we've had to use what I would call non-recurrent mitigation. So looking at balance sheet opportunities, slippage against non-recurrent spend, things we can do that effectively have helped delivery of the collective plan. It is just worth saying within that then that the ICB specific element was a £6.6 million surplus plan. We delivered that despite the pressures and the challenges we've talked about all year in relation to continuing healthcare and prescribing, and I do see those continuing to be risks as we go into 23-24. So that was the old financial year, Chair, and now I'll go on to the new financial year. So 23-24 and our financial plan. So as we previously discussed, the requirement from NHS England was to plan, submit a balanced financial plan and effectively live within the resources that we've been allocated. The final plan that went in at the beginning of May for our system showed that we had a collective deficit plan of £19.2 million. You'll see within the report that that significantly improved from the original March submission that we made. So effectively we improved by 36 million. In March we were still around the £55 million deficit. So a significant amount of work went in collectively in order to improve that position. You'll also see then within the paper that to support the overall plans across the system, the ICB redistributed £55 million worth of support. So £42 million going into Worcestershire Acute, which has allowed that delivery of a balanced financial plan, and £13 million then to Wye Valley, which again has reduced their deficit plan and ensures that they've got cash support to continue to trade during the financial year. Within the plan then, there are a number of challenges that we need to work through this financial year. So we've got £74 million worth of efficiency savings. So it's about 4.6%. That is a big step up from where we've been in 22-23. And again, a significant commitment to reducing agency spend down to around the £51 million level. Both of these areas are critical to ensuring that the system can deliver its deficit financial plan that we've put in at the moment. As a result then of having a deficit plan, we are continuing discussions with NHS England national colleagues around the implications of having that position at the moment. We can expect that the system will be given some enhanced expenditure controls, which will apply to all partners. And as well as that, we'll have to develop a medium-term financial strategy, which will fit alongside the joint forward plan that David's working on, and effectively allow us to look at how we get back to a route to balance, improving our underlying financial position and getting a recurrent in-year balanced plan. I suppose the way I describe it quite simply is we've got to live within the resources that have been allocated to us. And we can't keep having overspending plans each year. Once we know more about what these enhanced controls look like and how they will work, we will come back and update the board accordingly. It's worth saying the financial plan, whilst we've still got a deficit, is still not without risk. There are a number of risks. I've just highlighted two in terms of agency and efficiency. But we know we've still got continued inflationary pressures. We're not seeing any sign of inflation beginning to slow. We've also got ongoing pressures linked to continuing healthcare. Again, some of that is inflationary driven, some of that is demand driven, and we are seeing more pressures still against our prescribing portfolio, both in terms of pricing and demand. So as part of it, collectively, we're going to have to work out how we manage, understand and mitigate those risks to allow us to deliver. Within the position then, there's the ICB part of the financial plan. Now we did sign off a financial plan back in March, which was a balanced position for the ICB. And you'll see within the paper there's been further things we have undertaken from an ICB perspective that have allowed us to generate that surplus, which we've then redistributed. Quite simply, we've had to freeze all things we would like to plan to spend, investments, remove contingency reserves, and look at further balance sheet opportunities and supports that we can bring out to allow us to improve the overall financial position. The ICB is now at a position then where it has to deliver a £200,000 surplus, and effectively the ICB efficiency programme's gone from 15 to £19 million. So I'd summarise it, Chair, that we're not where we need to be or are required to be in terms of a balanced plan. We have a challenging position that we need to deliver in 23-24, and we know that we will be given further enhanced controls around pay and non-pay, and we will continue to work around the medium-term strategy and looking at how we improve our underlying financial balance. The key now is we need to deliver again. We need to start delivery on these plans, what we put forward, and get that continued assurance and understanding from the region and the national teams that whilst we're not where we need to be, we will deliver what we said we will deliver in terms of our financial position. So I'll stop there, Chair, and I'm happy to take any questions or comments on that.
Thank you, Mark. So a couple of people who want to come in. So David Whiteman first, and then Anita. David.
Thanks, Krishni. Mark, firstly, thank you for a really clear paper, really easily readable and absolutely clear in what it says. 3 points. One is a congratulations to all for delivering the 22-23 plan as the system said we would. I think that's really great under the pressure we've been, so fantastic, well done to all. 2 questions. You mentioned on page 7 that the board is asked to note the redistribution of 55.7 million of system funding impacts on the ability of the ICB to fund service developments in 23/24. So my first question is, could you tell us more what that means, because it feels like we're making a cut which might affect our ability in the future, and one of the things we're trying to do, of course, is to invest in advance rather than delay investments. That's the first question. And the second question is, are we sure that the focus that we have now on this really tight plan for 23/24, are we sure that will not impact quality and patient safety? I think we as a board need assurance on that.
Mark, are you happy to respond on the first point, and then we might want to bring other colleagues in on the second?
Absolutely. So in relation to the £55.7 million, so the way that was generated was through a number of different ways. So we had some balance sheet flexibility that was released. So again, we were able to bring that non-recurrent opportunity in, but we also know that we will be given kind of new allocations in year where there is always slippage against some of those for some developments. So service development funding, we know there's always a lead-in time. The big one really in terms of where we would have liked to have made more progress going into 23/24 was really priming some of the what we describe as left shift. Now I know we're going to call it something else, but really to drive some of that change, you need to put some kind of investment in up front to build some of that infrastructure to allow services to move and costs to step down. Unfortunately, because of the financial position we're in, it was made very clear we couldn't keep making new investment whilst we had a deficit, and we had to focus on stepping our costs down first before we started to look to make investments. So it's not where we would like to be, but I think through the work on the medium-term financial strategy and trying to move away from a annual financial cycle to a more longer-term financial plan and approach, that will allow us to make some of those investments, but at the same time continue to focus on cost reduction, efficiency delivery, and stepping down premium spend in areas which is what's driving some of the position we're in at the moment. So we can give you specifics, David, through the quality resources and delivery committee in terms of everything the ICB did, but as I say, the biggest proportion was around balance sheet opportunities and stretching efficiency programs within the ICB.
Okay, thank you. Will, did you want to come in on David's other point about
Yeah,
quality and safety?
I think the quality and safety point is a really important point, David, and that I've been thinking about this quite a lot, because it is really important that we make sure that we provide a really high quality, patient centred, while being fiscally responsible service. And I think actually what Mark has done is demonstrated that. You know, we have gone through it and we said we cannot deliver that without having a deficit, and we've proved before that we can do that. And actually some of the things in this plan will improve quality while improving our fiscal position. The agency spend is a classic example of that. If we tackle the agency spend and get more full-time equivalents in that are permanent staff, that will improve our quality. Kath and I have been doing quite a lot of work as well about around our quality forum, and making sure that that's sort of fit for purpose, really to do the stuff of things like Matthew has said in the chat, that we are risk assessing any of our decisions, and that is a very clinically engaged conversation. So yes, I completely agree with you, but I think we've got quite a lot of governance around this now, and actually I think there are opportunities here to improve quality and do this.
Yeah, thank you, Will. I think that's a helpful reflection. Anita.
Thanks, Krishni. Just an observation. So, I mean, first of all, I think congratulations to everyone, both in the within the ICS and also amongst partner organisations, to get us to the point where we got to on the 23-24 plan. That was not a given, and given where we started from, I think it really was a fantastic team effort. It's an obvious one, and I'm sure we're all very conscious of it. It has involved us pushing our PEPs, SIPs, whatever we're calling them, to I suspect the limits in all our organisations, and there is clearly risk attached to that. I think that's an obvious statement. However, I think what I am almost more concerned about is the problem with our SIPs and PEPs or whatever is that they tend to be in-year short-term transactional stuff rather than transformational. As an example, we can talk about freezing non-clinical posts. Well, there's a scenario that said it just means we're not going to backfill somebody this year, but hope that maybe we'll muddle through for a year or two and hope we can get back to filling that post later. The alternative is to say, actually, this gives us an opportunity to do the things we've always talked about in terms of a kind of a shared service model for some of our back office stuff. And so really what I want to urge the system to do is say, let's not use this. The easy thing to do is to just keep slicing a bit of salami off and actually hoping we can tide ourselves over for a year or two and we go back to doing things the way we always have done. And what I'm saying is, for it to be transformational, let's use this opportunity to really drive at a system level that stuff about back office, shared services or whatever. Let's do those things. Let's take the opportunity, because we're being forced to, of course, but actually it's something that we agreed as a collaboration. That was something we believed in and we wanted to do. So let's be transformational. Let's not be transactional. Let's not be short-termist, because actually we know full well, even if we manage it this year, next year will be just as bad, and the next year. And so we've got to start making changes now that are going to be long-term rather than short-termist. Thanks.
Thank you, Anita. It's a really strong point. I can see Simon wanted to come in. Was that in response to that point, Simon?
I'll come in at the end if you like, Christian.
Okay.
That's right.
Okay. Nigel?
Thanks. I was really going to make similar points to David, actually, in relation to the risks, the clinical risks that are around, driving down agency spend, which is entirely the right thing to do if you are recruiting into substantive posts as the solution. If you're doing it without doing that, then of course there is a potential risk for patient safety, patient services, and I think as a board we have visibility of the plan, but we may not have visibility of the mitigation. So we could get into a situation where patients are being put at risk because of the plan that we are approving, and it is, we have to do it, but I think we just have to have that assurance around we're not going to push things too quick, too far, and I would certainly benefit that. And I wonder whether we should be formally recording that on our risk register, and so that we can follow that up with due process.
Yeah, important point. Thank you. Thank you, Nigel. Mark, did you want to comment on both of those things before we get the last few comments from Simon and Katie?
I think, Chair, Will touched on it. I don't think we would ever push a financial plan to a point where quality and safety was compromised. It's about how we look at the finances alongside quality and safety. And as Will's already touched on, some of the things that are in our financial plan will improve the quality and the services delivered. So I think it's a fair challenge, and we will put it onto the risk register and provide assurance around the mitigations and any decisions we made, how we're following that quality impact assessment.
Thank you, Mark. I mean, I suspect we will all feel the same, but I've always held the view that I would be much more willing to be hauled over the coals for failing to achieve a financial target than putting patients at risk from a safety point of view. So I think we would all acknowledge that, but as Mark has said, that there are some real opportunities here which are actually enabling better quality. Certainly the agency spend is the one that I think we keep coming back to, which everyone acknowledges, and indeed Katie commented at the beginning, has a quality aspect to it as well as a financial one. Thank you. So we have some final comments, I think, from Simon and then Katie. Simon?
Yeah, thanks, Christine. Just a couple of things. And I think I'd echo Anita's point around we should just stop and reflect what a good job people have done and what an open approach people have had as a team across the system to get this to a position that we can sign it off and NHS England could sign it off. That was a monumental achievement, really, over a number of weeks, and fair play to people for the ingenuity that they showed through that process. I just wanted to draw attention to this. Felt like a sea change in the financial approach across the NHS. We obviously had a few years over the pandemic where our budget allocation was matched with a series of other access to other funds to do what needed to be done. I think even last year, if we're honest, there were elements of that within the budget setting process. This year felt very quickly like back to kind of it did in the 2010s, 2015, 16, 17, when it was a real struggle, particularly in this system, to get the budgets to balance. So I just think we need to recognise a sea change in the national approach. We are allocated a sum of money to provide health and care services for our population. We have to find a way of living within that sum of money. That's our job. That's our job as a system. That's our job as individual organisations. We have to have plans that allow us to live within those spend limits that we are given. When we go above them, in essence, we're spending other people's money, and that isn't acceptable. A couple of more positive things, though. I think you don't do that overnight. So we found a plan, I think, that buys us time this year and gives us a bit of headroom. Whilst being stretching, it also should give us some headroom to focus on a medium and longer term direction of travel where we improve the underlying position. So be under no doubt, this plan gets to the number it gets to through a series of non-recurrent sticking plasters, some fortuitous, some one-off, some slowing down of spend that we'll have to spend eventually, but we slow it down through this year and accrue some underspend that can help balance the position. So it's buying us time. We do need, though, to really commit over the coming months to understanding our journey, the stages on a journey to an underlying balanced position. And Christine, when we went to see Amanda Pritchard and Julian Kelly, the National Director of Finance, offered to help and support us with that journey. I think we should take that up. My final point is also a team-based one. These plans are undoubtedly incredibly challenging. We have a much greater chance of delivering them if we help each other, though. And so our job is not only to do our bit, it's also to help our partners and our other teammates deliver their plans. And there is so much that we can do by supporting each other, both in terms of how patients progress around the system and making sure that's efficient and the right thing to do for patients, but also how we help each other to make that happen. Shifting responsibility and cost around the circle doesn't help, and I think this financial planning process is a perfect illustration of that. We can send all the patients to the hospital, but if the hospital then incurs all the costs, there's just no money to invest in primary care or community services. So we just have to understand that fairly circular process we are now in, where it's in all of our interests for all bits of the system to work. And things like back office streamlining have got to be part of the work we do this year. I think that can get us some better outcomes, but also critically, it's got to make us more efficient and help us spend less on some of those services to free up resources for frontline. So just a few reflections on how important it is that we stick together now and help each other deliver our plans.
Thank you, Simon, and thank you, Mark, for your leadership on this, and indeed the contributions of all colleagues who've been involved in delivering certainly last year's number. I don't think there were many systems actually that achieved the planned number. Mark will know better than I how many, but I know there were a number who slipped their plan during the course of the year. So I do think we have to, albeit we agreed a deficit plan, you know, we delivered on our number, and that is important to recognise. I think lots of colleagues have absolutely rightly made the point that we need to think, albeit we've agreed a plan that we had to work quite hard to develop and agree in a very short timescale. We do have an opportunity to think medium term as well, and it's really important that we start that now. I think one of the challenges we sort of reflected on is, you know, the planning guidance lands on usually December the 23rd or 24th, depending on whether it's a Friday or a Saturday, and then we all rush to develop our responses to that. We need to get ahead of that and understand what we think transformationally we can do. And certainly I'm really keen to see, you know, we've all committed and suggested that we're willing to think about, you know, what back office, how working together in particularly on things like, well, it's working at scale really. It doesn't matter. It's not about structure. It's about how we can do things once together rather than all of us doing things separately. And I think Russell and others have made the point where the system can add value to that rather than duplicate. So if we can collectively do things once together, I think in very simple terms, those are things that will make us more efficient. And we certainly need to think medium and longer term, because otherwise we never break the cycle, I think, of getting into how do we actually, you know, stop our particularly patients, you know, ending up needing acute services, because actually we know that if we invest in prevention, we have a better chance of avoiding costs longer term and providing a better patient experience, which are, you know, equally important. So thank you. Mark, any final comments from you before we close on that item?
No, thank you, Chair. I think they've all been covered.
Great. Thank you, everybody. So our final report is our Board Assurance Framework Report, which is obviously covers our key risks. Hannah, do you want to highlight any key points from that?
Yes, thank you, Chair. And I think it's really interesting, you know, how important our risk management, our effective risk management process and systems will be going forward, particularly given some of the discussions we've just had around balancing finance and quality. I think our risk management will become ever more important, really. So this is a summary report. You are well used to the format. Hopefully you can see a clear link between the risks that you see within this report and the conversations we've had in terms of our priorities and our strategic and corporate risks. Specific changes are summarised on page 3, so I'm not going to go through that because I think lots of those conversations have already been had today. I did want to highlight 3 things really that the report hasn't covered. So Firstly, now that we have got our integrated care partnership strategy in place and we are working towards finalising our joint forward plan, the ICB will need to review its priorities. So this is work that will need to be done over the next few weeks. And David Mahaffey and myself are hoping to bring a piece to the next board development session to progress some of those discussions. And that will obviously have an impact on some of the strategic risks that we will identify as a result. Secondly, a lot of work is currently underway in terms of reviewing the governance and assurance of system programme boards, and that's a piece of work that's being led by Emily Godfrey, the ICB Director of Planning and Assurance. And as part of that, we are reviewing how programme boards identify, manage and report risks. And I think this is a really key opportunity in us starting to drive a system risk management approach bottom up from those programme boards, because actually everything we do in the system, everything we need to deliver is covered by one of those programme boards. So that's a really exciting piece of work that will kind of hopefully come to fruition over the next few months. And finally, a bit of good news. We recently had our internal audit report on effectiveness of our board assurance framework and associated processes, and we have received full assurance. So that's really just in the last few days. So I have got nothing else I would like to raise, but I'm happy to answer any questions, Chair.
Thank you very much, Hannah. That's a really important piece of news. Sarah Raystrick.
First of all, well done on that last piece of news, but also just a point on one of the risks that's increased. So strategic risk 2.2. Just interested that talks about lack of assurance in respect of efficacy of provider collaboratives and place-based partnerships. So my question really is, I wonder, as a board, what else we can do to be seeking the right assurance or providing support to provider collaboratives and place-based partnerships, especially given some of the reference earlier to the community paradigm, to fuller report and to the primacy of place within our system.
Thank you. Yeah, so it's a really good question. So this is a bit of a process issue, really. What we have done is we have, following the agreement of our risk appetite, we have reviewed the relationship between some of our strategic risk scores and our corporate risk scores. So under strategic risk 2.2, which is the provider collaboratives, we really only currently have one corporate risk, which is linked to Herefordshire safeguarding services. That risk is currently quite high, it's 16, and it didn't quite flow that our strategic risk was actually only rated as 9. So it's not necessarily that something has necessarily decreased or sort of we've kind of deteriorated in any way. This is more of a reporting issue. Again, something that I think will be addressed as part of the review of our strategic priorities going forward. There's clearly an awful lot of work in terms of the collaborative work, be it in terms of the mental health collaborative. So this is a bit of a fluid area, but it will be looked at and reviewed ahead of the next meeting.
Thank you, Hannah. So it's more a refreshing of it to make sure it felt at the right level rather than
a bit of a moderation, really.
Yeah, increased level of risk. OK, thank you very much. OK, thank you. So if there are no further comments or questions on that, and we noted, I think, the suggestion that the sort of financial plan and the risk associated with the sort of getting that balance, we'll need to just make sure that's appropriately reflected going forward. But I think we can close on that item. We have the committee minutes available for noting and for transparency to board members. If we wouldn't normally talk through those, of course, so I just paused momentarily to see if there were any questions about any of those minutes, but if there are not, as I say, they are simply there for noting. And the final item is really just to confirm that our next meeting is on the 19th of July in public via Microsoft Teams. And I just really want to say, well, we've although it feels like we have had a very comprehensive discussion today, we've actually finished a little bit earlier than we planned, but I'm sure nobody will complain about that. So I just want to thank everybody for their contributions today, and indeed contributions to the items and the preparation. We shouldn't underestimate the amount of time these things take to be done. So thank you to all colleagues who were involved in that, and I really look forward to working with colleagues over the coming year to deliver the commitments that we've made. So thank you everybody, and see you formally in July. Thank you.
Thank you.